What they're reporting here is the progression-free survival of the two arms, depending on first at the time of the first switch, in that first progression-free survival, and then also when they then switch to the other therapy, what their progression-free survival is at that point. And so interestingly, but perhaps not necessarily surprising, is that the arm that switched to immunotherapy had a harder time on both times, at both endpoints. And so switching to immunotherapy is risky. So here, switching to single agent therapy, several patients then lost their response. And so at the first progression-free survival, the arm that continued on targeted therapy did better, and then also when they switched later from IO, the arm that switched to IO did worse. And so they worded it as a switch only the second time, saying that the first time it was just that they stayed on it, but really I think what we see here is that single agent immunotherapy for this population is probably not as effective. I think this has been also a big argument when people looked at DreamSeq and thinking about triple therapy as a frontline as opposed to IO combo alone, sort of trying to have a, how should you say it, a compromise by having a triplet regimen. And the concern there is also that then the IO is single agent. And so if you're relying on immunotherapy in this population, I think timing at which point you're using it and which regimen you're using it is important to consider.